Our next speaker is going to be Dr. Rashmin Gandhi, who's a practicing neuro-ophthalmologist from Hyderabad and is also a consultant and Center for Sight Group of Hospitals. And he is going to talk to us about basic neurology exam every resident must know.
I would like to thank Dr. Chitra and the entire team of ARC for giving me this opportunity. It's always a pleasure to be part of these programs. So today I'm going to talk about the basic neurology and neuro-ophthalmic examination techniques that each resident should be aware of. There is a little blur between neuro-ophthalmic techniques and neurology techniques, and I'm just going to cover as to what would work for all of us. Now, there are two examination techniques that we routinely deploy, that is examination of pupils and examination of ocular motility. I'm going to stretch it a little bit to say that in a lot of our programs, some of the techniques about pupillary examination motility is not very well covered, or sometimes we miss out on some of these techniques. So let's first look at pupil. We all check pupil routinely for an efferent defect, and that test is swinging flashlight test to find out whether there is a unilateral optic nerve defect or asymmetrical bilateral anterior visual pathway optic nerve defect. However, a lot of times we miss out on the efferent pathway, examination of pupil with regards to efferent pathway. Any lesion in the efferent pathway of the pupil gives rise to anisocoria, and that can be a very important telltale sign of an underlying, sometimes serious disorder. For example, anisocoria in the setting of third nerve palsy can be a sign of compression of third nerve because of aneurysm of the posterior circulation, most commonly posterior communicating artery, which can bleed and can be potentially fatal. That's an example of anisocoria because of a parasympathetic system problem. We can also see anisocoria because of a sympathetic system problem in Horner syndrome. And let's look at an example and why it is important for us to know about this. So this is a young man who had a fall, an accident, and had history of headache, and he comes to us. And you can clearly see here that the right pupil is smaller than the left pupil, though there are other signs of Horner syndrome are absent, but you can see that there is an anisocoria. What is the next step when you see a patient with anisocoria? The next step would be to examine the patient in a different ambient light illumination, examining the patient to say what happens to anisocoria when the ambient illumination is very bright versus when the ambient illumination is dim. If the difference in pupillary size remains the same when you change the ambient illumination, you probably may be dealing with physiological anisocoria. If the anisocoria worsens when the ambient illumination is dim, you are dealing with sympathetic system problem, because in a dim light, in a dark environment, the pupils are supposed to dilate. If there is a sympathetic system problem, then that abnormal pupil, smaller pupil, will not dilate, as would have been a case in our patient. If anisocoria is worse in a bright light, then you're dealing with parasympathetic system problem. The causes can be third nerve palsy, Adis pupil, or pharmacological pupil. Now, why this is important? As in a patient who has an acute Horner syndrome in the setting of trauma, you might be dealing with dissection of larger vessel. The initial presentation of dissection of larger vessel can be acute, painful Horner syndrome. So pupil, we must know, apart from RAPD, swinging flashlight test, we must be aware of anisocoria and should be looking at anisocoria in patients, especially who has trauma or third nerve palsy or headaches. And the next step when we see a patient with anisocoria would be to examine the anisocoria in a dim and a bright environment. Now let's look at the ocular motility. Now this is a patient who has ptosis of the right eye, Now the smooth pursuit movement is being checked when patient is following a target. There are two movements, important movements that we should be aware of. Smooth pursuit movement, which is a slow ocular movement where eyes track a slowly moving object, versus a saccadic movement where you bring the object of interest and fovea and it's a fast movement. So here we found that the patient had a reasonably good smooth pursuit movement. Now let's see what happens when the saccades are being tested. And that's the importance of knowing or examining saccades. And you see here, when the saccades are being tested, you find that the right eye, though it is reaching to the end point, but it's moving much slowly when you ask the patient to move the eyes fast. So slowing of saccades can be the only sign in somebody who has a mild nerve palsy or a recovered nerve palsy. Slowing of saccades can also be a sign of various degenerative diseases of the brain. So it's important for us to know how to check saccades. I'll show a video. In the next video, I'll also demonstrate the technique of examination of saccades. This is a little long video, so bear with me, but in this video would cover almost all the examination techniques that we should be deploying, and I would like to acknowledge my alma mater, Shankar Netrala, because this patient I saw when I was working there. So let's see, first, when we are checking a smooth pursuit movement of this patient, and you'll find that there is a limitation of abduction of the left side. So this is how you check the smooth pursuit movement. A slow moving target, patient follows the target to the right, to the left, to up and down. Now we go to checking of saccades, and this is how you check saccades. Two dissimilar objects here, patient is looking at the pen and is looking at your nose. Pen and nose. There are three characteristics: latency of saccades, speed of saccades, and accuracy of saccades. How fast after you've given a command, patient initiates the saccades, whether it's symmetrical in the eyes, and whether it's accurate, or is there a jerk before he settles down on the object, because that can be a sign of a cerebellar dysfunction. So saccadic movements, testing of saccadic movements is important. Now we are checking the seventh function. Here we are looking at the orbicularis oculi tone. Patient is asked to raise his eyebrows, move his jaws. So that's the seventh now. Quick examination of the eighth now to see whether hearing is all right on both sides. Now the confrontation sets test where patient looks at either your nose or your eye, and then you present the object in different quadrants to see. You look for RAPD, the pupillary examination. Now this is a red desaturation test where you present a red object in the temporal and nasal half, and this is a brightness sensitivity test where you ask the patient to look at the light and ask him to compare the brightness between two eyes. So these are effectively the tests that you need to perform. So what we looked at in this video, we looked at how to check for saccades and importance of checking saccades. Seventh, eighth nerve. What this video did not show was examination of the fifth nerve, which also is a very important tool. You should look at the corneal sensation and also check the sensation on both sides in three parts of the face. The cerebellar function test also becomes important in these patients. Why these tests are important? Because fifth and sixth nerve, for example, in this patient, fifth and sixth nerve can be together in cavernous sinus. Sixth and seventh nerve are together either at the CP angle or in the pons, the nuclei. The facial nerve makes a colliculus around the sixth nerve nucleus. Again at CP angle, you'll find the auditory nerve, vestibulo-ocular nerve to be closer to the sixth nerve. That's why cerebellar function test also becomes important, because of the lesion can be potentially either in the pons or at the CP angle or in the cavernous sinus in these patients. Let me show you an example. Here is a patient who you can see there is a little right fullness of the right upper eyelid because he underwent a gold weight implant because he had a seventh palsy. And when you see when the patient is trying to look to the right, The right eye is not abducting, the left eye is not adducting, implying that there is a right gaze pulse. In this patient had a pontine lesion, because of which there is a right gaze palsy, and also a seventh nerve which was corrected with gold weight implant. So that's the importance of knowing some of these examination techniques. You can effectively localize where problem is likely to be. So to summarize, the examination techniques which we should all be aware of and should practice either in an exam or in a daily clinical scenario is to look for anisocoria and see what happens to anisocoria in a dark and bright environment. Confrontation test, motility apart from smooth pursuit, which we all check, should also be aware of checking secants and vestibulocular movements. Examination of the seventh and the fifth nerve, we should be aware and should be checked in all patients who present to you with a probable sixth nerve palsy. We should also be aware of checking the other cranial nerves, like as I mentioned, in vestibulocular nerve. Cerebellar function test by performing finger nose test, pass pointing, dysdiadochokinesia, and a general motor and sensory function, including the reflexes after knee jerk and ankle jerk, would be an important examination technique that you should be deploying. So with that, I end. I thank you once again for this opportunity, and thank you for patient listening. Thank you very much.
Yeah, that was a good talk of Dr. Rashmin. Dr. Pradeep Sharma, I wanted to ask you a question. With the limited access to drugs which we have, how can we diagnose Horner syndrome?
I think what Dr. Rashmin also highlighted, at the outset, one has to see whether it is worsening in light condition, darker condition, then it is going more in favor of Horner's. So that is one thing that you'll have to see. The associated features also would help. Like if there is a ptosis, if there is enophthalmos, then again, if there is a ciliospinal reflex. So those are the points which may help you if you do not have drugs at your disposal, which is correct that we usually will not have the amphetamine or the cocaine drugs to help us. So the clinical examination itself can actually lead you to the diagnosis of Horner syndrome most of the times.
Dr. Murli, should we go on to our next speaker? Yeah.
Yes, sir. Yes, madam.